Prof. Hamdan will be talking about the Saudi COPD guidelines. Prof. Al-Jahdali is a consultant internal medicine, pulmonary and sleep disorder adjunct professor at McGill University, head of pulmonary division, medical director of sleep disorder center. Please welcome Dr.
Thank you, Dr. Hajar. Assalamu alaikum. Bismillah ar-Rahman ar-Rahim. Wassalatu wassalamu ala nabiyyina Muhammad. First of all, I would like to thank the organizing committee, Dr. Al-Jahdali, Dr. Moteri, Dr. Hajar for inviting me. And also, I am honored also to present this Saudi guidelines on the behalf of my colleagues that I'm going to show their names shortly. I'm lucky that Dr. Othman and Dr. Asir already talked about epidemiology and the impact and the burdens of COPD. That saved a lot of time for me. But briefly, as you know, COPD worldwide, globally, there is more than 162 studies in one of the meta-analysis and show the overall prevalence of COPD globally around 10. In MENA regions, Dr. Masjidi and his colleagues, they looked at 92 studies also, and they found the prevalence in MENA regions approximately 5.3. In Saudi Arabia, we have two studies, one by Dr. Siraj Wali and the other one by Dr. Obain, and which showed that overall prevalence of COPD around 4.2, but when you look at smokers, there's approximately 14.2%, which is really a high percentage. Asiri was asking what the prevalence of smoking among Saudi. This is data from Ministry of Health, GATE, 2019. I think this is the latest one, and showed that overall prevalence of smoking in Saudi Arabia approximately 20%, and 30% in men, and 4.2. But recently we know that people they smoke more, especially with vape or vape. You can see them in the street, everybody using this kind of smoking. So I presume that over time we're going to have more prevalence of COPD. We have to be ready. And I know one of the policy of Ministry of Health, as stated by the minister, that the aim is not to treat the disease, but to prevent the disease. And I think this is a good policy, and we should act quickly, trying to at least, probably you cannot stop people from smoking, but at least you make them aware about the risk and the burden of the disease in the future, and you put all the resources for this kind of educations. I'm going to talk about 2024 national COPD guidelines, but this is a kind of collective kind of efforts. And here we have the names of my colleagues. Dr. Riyad Al-Hebi is here, Dr. Faz Al-Hijali, Habis, Dr. Swayan, Ali Al-Araj, Majd Idris, Mohammed Zaitouni, and Hani Lababidi, Osam Al-Hamad, Shmemri, Al-Ghubain, Al-Muammari, and overseen for all these logistics by Dr. Ziad Mimish and Dr. Al-Jahdali. The guidelines actually has a robust team from Elsevier. As you could see, there's a big names there. They are expert in reviewing the literature and compiling it and come with very robust kind of recommendation-based evidence recommendations. So that's what we did actually. And finally, we want to be sure that what we are saying makes sense. We ask for 3 international reviewers. One is Darcy, someone from Canada, Dr. Kostikos from Greek, and Dr. Barpo from Montreal, Canada. So they did the review, and they have also the recommendation that was incorporated. The aim of this guidelines, actually, it was to facilitate decision-making, clinical practice, including targeted people, including pulmonologists, family medicine, internists, anybody who can see COPD. and also to try to improve the outcome of COPD patients by controlling their symptoms and try to decrease exacerbation as we can do. And also, it is also for stakeholder to make policies. And also, it is updating CCAD, which is Saudi Thoracic Society COPD guidelines, which is outdated. The last time was published in 2014. We used actually existing guidelines, including NICE guidelines, GOLD guidelines, and Canadian guidelines to try to help us to make a good recommendations. So the guidelines was evidence-based medicine, basically talking about pharmacological treatments, long-term oxygen, role of non-invasive ventilation, bone rehabilitation, steroid and antibiotics, and also early discharge, and many or two other questions. There's a lot of efforts done, but I have to mention upfront that this guidelines is different from all other guidelines that I have been part of it. We usually go through epidemiology, then diagnosis, then treatment, and you go through also discussion. So it is somehow is inclusive. This one was only for treatment, mainly management of patient with COPD. We did not discuss the diagnosis or other aspect as well. We did not address the comorbidities, what you should do it, which was covered by Dr. Othman. So some kind of targeted kind of guidelines is coherent with what the national committee that they're doing these guidelines for many other diseases to be just to guide physician how to manage the patients. We assemble 13 experts that I listed their name. We have 13 meetings. Each meeting lasts for almost 2 hours, and I would like to extend my thanks also to all my colleagues because it's all done after 9 o'clock from their own times. And initially there were 33 questions, and we have been told you only have 10 questions. So you have to be selective. So we choose 10 questions by consensus. And during the discussions, actually, there's 2 questions raised and we added, and as if it was accommodative. There was more than 30 systematic review. There's more than 6,000 papers were reviewed and abstract. There's more than 52 full text double screen. Finally, we have almost 24 meta-analysis. We have more than 109 first kind of evidence grading. And then we have our recommendations with the evidence. But also we used grade Pro that you know, which is used by many guidelines. But our task was actually, once we have all the evidence graded, then we have to address all these questions. And that will make our adapted kind of guidelines. Because sometimes not only evidence, you need to see your guidelines, your recommendation is adaptable, is applicable or not. So first of all, we have to agree about the benefit of harm based on the evidence. Did the studies that we reviewed meet the targeted outcome or not? And then what the value of these recommendations? And then feasibility if this recommendation implementable or not? And do we have the resources, and it is also cost effective to implement? And then equity. And equity, this is a word that confused us. We spent a lot of time just to put our mind, what that does mean. But basically mean that if you make these recommendations, the drugs will be available for all, and also will not be at the cost of other medications. That's what we mean by equity. And then if you make a recommendation, is it going to be accepted by stakeholder and physician or not? So all of this together with the evidence-based grading, we have our adaptable or the final recommendation of our task force. So it was good exercise actually to go through it. There is a few things I have to mention at the beginning just to, yani, this is very important, this definition, to set the scene for the recommendations. So we always have to, for any patient with COPD, first of all, after we diagnose, and the diagnosis is based on FFE1 or FFEC less than 70%. We did not discuss young COPD. We did not discuss BRESM. We did not discuss pre-COPD, our target, those who already have established COPD. What we should do about them. So we know that we always start with the symptom score. We can use CAT score, which is almost 40. Anything less than 40 means less than 10 mean they have less symptoms. More than 10, they have more symptoms. And also MRC that you know for a long time, and also exacerbation and hospitalizations. Well, it's 4 minutes. I'm almost. And of course, you know, this score, the last table there in the corner is very important to differentiate between severe and very severe based on the FFE1. Anything less than 50 or 30 is not severe and very severe. And also COPD exacerbation, who has to define it. And there's a lot of discussions, but it basically mean the patient has symptoms less than 14 days, worsen over less than 14 days. And also we adopt basically Rome kind of definitions, although we did not spend a lot of time, but you also have to have, in addition to the symptoms, inflammatory markers and also some kind of physiological findings, like a little bit of low oxygens, tachycardia, tachypnea. For those who did not see Rome, it is a very good, actually, because symptoms is some kind of subjective. And you're going to base your judgment and treatment only in symptoms, somehow, sometimes deceiving. So I think this is a very good, although we did not include it in details, but we agreed about the concept of COPD exacerbation. Stable COPD, we have a lot of debate how we define it, but finally, we said COPD patients stable when they currently have no symptoms, regardless of their previous exacerbation. Maybe they have exacerbation before, but currently stable, they have no symptoms, then we'll call them stable. And we use this kind of scoring that you know about it. I'm not going to spend a lot of time because I'm running out of time, but you know about A, B, E. This is grade of severity. It is the same one adopted by CCAD a long time ago, but for some reason or other CCAD, they did not put MRC, which is very easy to remember and more practical comparing to CAD, where you need someone to score the patients. So the question one was, should long-acting muscarinic antagonist, LAMA, plus LABA, over LAMA alone should be used in patients with COPD or not? What the evidence? The moderate evidence showed that combination of LAMA and LAMA better than one of these two. And adaptable kind of recommendation, our task force, they basically mentioned that you have to consider dual LAMA and LABA in patients classified as group B and E, which is honestly not different from other guidelines, but this is our own evidence-based medicine grading, which came to the same conclusion. The question two about triple therapy. Is LAMA plus LABA plus inhaled steroid a preferred over LAMA in patients with chronic obstructive airway disease? And again, we look at the evidence. We look at mortality. I think we have another sessions because mortality was not included, and we have again a debate about it. But the evidence show moderate certainty of the evidence in all endpoints that we need, including FFE1, symptoms, and also mortality. So it was recommended to use it in patients who has more hospitalization, one or more, or they have exacerbations. And our adapted kind of recommendation, basically, yes, to use triple therapy in any patient who has exacerbation 2 or more, or they have one hospitalization, group E, particularly if they have eosinophil more than 300. If they have eosinophil less than 100, it's better not to use steroid because it's not going to be effective, most likely, and also going to have a side effect. So in these kind of patients, they have less than 300, less than 100, to use only combined therapy, LAMA and LABA. The question 3 about BDE, 4 should be used or not, and when you should use it. And although the evidence was not very robust, was very low kind of certainty, we recommend that in patient who has severe COPD, severe also severe, mean less than 50 or less than 30, but they have history of exacerbations, and I think also they have chronic bronchitis. So in this kind of patient, is recommended to be used. Question 4 was, should we use mucolytic or not? The evidence, again, is not very robust, very low evidence. And our recommendations, adaptable, was to use it in combination with the therapy, but it should not be used as a monotherapy. The question 5 about oxygen. Should long-term oxygen therapy used in patients with COPD? And there's a lot of debate about what about patients who desaturate with exercise or desaturate during sleep. Should we include them or not? But basically, we mentioned that it should be used according to MRSA and long-term oxygen therapy trials, which is mean oxygen less than 60 or less than 55 or 54 if they have comorbidities. But for those who they have mild hypoxia, we should not use it because it has its own risk. We make also another condition that although this is a recommendation, you always have to take case by case. Some patient with severe heart failure and they have COPD may be going to beneficial, so make it also somehow some flexibility to the patient to use it in that context. Question 6, should shorter duration, less than 7 days of corticosteroid used or not? The recommendation is very clear that you should use it. If we're going to use it, we should use it for less than 7 days, although the certainty is not very high, but this is the consensus of our group as well as most of other guidelines. And also we make notes about you have to think about the side effect of steroid and all these complications when you give patients steroids. So you have to be very careful not to give it more than necessary period that is required. Question 7, should antimicrobial intervention versus no antimicrobial intervention used in acute exacerbations? There is very low certainty. It's common practice that people, they use it for exacerbation, and the recommendation basically to use it for patient with exacerbation. Some members somehow they question the evidence. Yes, the evidence is very low, but it's very difficult to keep patient without antibiotic if they exacerbate. So question 8 about non-invasive, should it used or not for the acute setting, in acute exacerbations in monitoring unit, including intensive care or high dependency area? Again, the evidence is not very certain, but we also recommend to use non-invasive in patient with hypercapnic COPD exacerbations. Honestly, this is the standard of practice. This is the consensus kind. The evidence is not very robust, but that's what we recommend. Should certain criteria be followed before the patient discharge? There is no much of evidence, but we recommend that the patient has to be assessed, be sure that he's treated appropriately for his COPD exacerbations. All the comorbidities was addressed, he was giving educations, and also given appointments, and we sure that patients should be referred to rehabilitations. Question 10, that easy, about rehabilitation. The evidence is very strong and we recommend it. And I hope that will be more investment from many hospitals, and probably Wizat Saha invest in this. Rehabilitation for COPD is really important. It's one of the cornerstone of treatment of COPD, and we recommend it strongly. 11, what about patient who has hypercapnia but they are not exacerbation? Should we use non-invasive ventilations? You know, there's a lot of cost, a lot of concerns. Also, you're giving non-invasive, and the literature was not very, the evidence is not very strong, very low. Our recommendation, if the patient still have hypercapnia 2 weeks after exacerbation, probably should consider giving non-invasive. That's based on our consensus rather than evidence. The last question, sorry, I took longer time. What about prophylactic antibiotics for patients with COPD? Should we give them prophylaxis to prevent? Actually, the evidence is very low. No good study to produce a good evidence. Our basically recommendations to consider Zithromax in patients who has severe COPD, especially if they don't have especially if they don't have eosinophils, neutrophilic kind of COPD, meaning group E with no eosinophilia. With this, and I would like to thank you for the invitation. Sorry, it took more than expected. And I hope these guidelines would be implemented and followed. I'm ready for your questions.
Thank you very much, Prof. Al-Jahdali, really very nice presentation. My first question, do we have, when was the last COPD guidelines, if we have, in Saudi, if there is something previously?
This guidelines was CCAT, Saudi Initiative for Chronic Airway Obstruction, or something like this, or disease, by Saudi Thoracic Society. Most of the people that I mentioned, they were co-author. It was published in 2014. It's never been updated. We hope that we'll take all these data that we work very hard to produce, to transfer it to the old version of CCAD, and we'll produce Saudi Thoracic Society. But we will discuss all other aspects of COPD, including definitions, diagnosis, and so forth.
Perfect. Thank you very much. Being biased to my profession, were there any clinical pharmacists in the panel?
The short answer, no. Why, I don't know, but it was, suddenly they said, we want people to lead this. It is, I am very careful with these kind of political things. So if we change the old ones, the members, we put new members, people, they will be not happy. So we said, let us start with the first group, and we injected with few enthusiastic, very knowledgeable people. So this is the way.
Inshallah. Inshallah, next time we'll be there, inshallah. Any further questions from the audience? When do you think that it will be live, inshallah, this guidelines? Is it...
This is a task that came, I think, from Wizat Saha, chaired by Ziad Mimish, I think, and others. They communicated to Al-Zafir, and Al-Zafir communicate to a group of ophthalmologists, including myself, and we assembled this. They took it, we signed it, we approved it, and they said it will go to the final kind of revision. I think it already went through the final revision to be adopted by the Minister of Health. So they will put it in their website, but we, as I mentioned, we're going to have our Saudi Thoracic guidelines, which is almost will be the same. And that will be our responsibility as a profession to disseminate it.
Allah يعطيك العافية دكتور Professor. Thank you very much.